for inviting me to give a talk. In fact, I was a little bit puzzled about when I was supposed to talk on heart failure prevention, because this is a very important aspect that we all should know. And why is heart failure prevention necessary? In 1933, Lewis had said that the very essence of cardiovascular practice is the early recognition of heart failure. I highlight the words early recognition of heart failure. This is what we as physicians, as endocrinologists, as diabetologists, and as cardiologists first somehow have to recognize heart failure. Now, if you try to see the cardiovascular continuum, which you are all aware of, these are the major four risk factors, whether this is diabetes, hypertension, atherosclerosis, smoking. These all ultimately lead to atherosclerosis. Just a minute. These all lead to atherosclerosis. And when atherosclerosis sets in, it all leads to coronary artery disease, ischemia, thrombosis, MI, reduced contractility, remodeling, finally heart failure. My job is today to see that where we can stop this continuum so that we can prevent heart failure and our patients do not go to heart failure. To discuss these issues, I'll be bringing some luminaries who will be asking certain questions. This gentleman is always in the news for no reason or some specific reason. If you ask the question, is heart failure an area of concern for diabetics? Yes, it's an area of concern. Because if you'll see, heart failure increases almost 2 to 5-fold when diabetes is there. But the other conditions you see, whether stroke, coronary artery disease, deaths are also equally high, but heart failure is something which goes unrecognized. And if you try to see which is the first manifestation of type 2 diabetes-related CV disease, after peripheral artery disease, it is heart failure. And type 2 diabetes trials have shown that heart failure is prevalent in almost 10 to 30% of the patients. And chronic heart failure trials have shown almost 30% of patients. So each 4 patients you see, at least there will be 30% of your patients, 100 patients, 30% of patients who must have already gone or are due to go to heart failure. Now, what we as physicians do, or as diabetologists or endocrinologists or cardiologists do, we treat it as 2 entities. Either we treat heart failure or we treat diabetes. But we have to realize that diabetes ultimately one or the other day will go into a chronic heart failure. And this is where my topic comes. How can we prevent this? Because all these factors, hyperglycemia, insulin resistance, all these things lead to chronic heart failure in the long run. Now, what is the prevalence? For each 1% increase in HbA1c, the risk of incident heart failure increases by 8% to 36%. So 4 to 8 times higher versus non-diabetic patients. So this highlights a problem that this is really a big issue and we have to recognize this earlier. What happens when these patients go to this thing, heart failure? Usually after they're diagnosed, gradually within first heart failure hospitalization, you'll see the time span goes decreasing and soon within 4 hospitalizations, they ultimately lead to death. So this highlights the importance that heart failure has to be detected early. The next question this person would like to ask, why is it important to detect heart failure in diabetics? Let us see. Now, we have 4 stages of heart failure. These are the 2 stages, that is stage A and B, where we can do prevention. But when the patient goes to stage C and D, nothing can be done because already the patient has had signs and symptoms and has refractory heart failure. So just to highlight that as the patient starts sliding down, the patient's quality of life decreases and the mortality does increase. A great criteria, if you ask you, why do we mean by early detection of diabetes? Early detection of diabetes, as per the ACC-AHA, clearly states that it is stage A, stage B, or stage C1. There is no limitation of physical activity, no symptoms. These are the patients who are at risk of developing heart failure. Of course, when the person comes to stage 2, stage 3, stage 4, these patients are easy to detect and have existing heart failure. Now, these first 2 stages of A and B are very important, and it suggests that over these patients who are at risk of developing heart failure, we can have therapeutic interventions introduced even before the appearance of LV dysfunction or symptoms can reduce the population morbidity and mortality. Now, if you try to see what are the various types of heart failure, it can be reduced ejection fraction or preserved ejection fraction. This is an entity which we have started recognizing more and more. And as we go through this entity, we have the mid-range ejection fraction or the recovery ejection fraction. Now, anything less than 40% ejection fraction on an echo, this is the echo diagnostic criteria, is reduced ejection fraction. Anything more than 50% is preserved. Between 40 to 50%, we have this mid-range or recovering, because the reduced ejection fraction can gradually improve with therapy and can go to preserved ejection fraction. Now, this gap between preserved ejection fraction and reduced ejection fraction is very little, because these patients of preserved ejection fraction have an equal bad mortality and morbidity as compared to reduced ejection fraction. So here comes the issue that we have to recognize this. We don't just recognize this entity, we have to recognize also those with preserved ejection fraction. This young, beautiful lady, actress, daughter of a very senior actor, how do we detect heart failure in early diabetes? Signs and symptoms? By doing certain biochemical tests, electrocardiography, echocardiography. Now, what are the signs and symptoms? A diabetic may first come to you telling, I'm short of breath, tired, some swollen ankles, loss of appetite, coughing, dizziness, abdominal bloating, sleep disturbance. These symptoms are usually confused with other diseases, and we ignore them. But in any diabetic, we have to be sure that possibly is my patient going into heart failure? And that is where we start doing an ECG. If you see a normal ECG and a patient with congestive heart failure, where the patient starts having widening of the QRS, the various parameters which are source, LA overload, LV hypertrophy, bundle branch blocks, and of course, these all indicate and gives us an idea. Suppose the patient has gone to atrial fibrillation, from ECG we can pick up a lot of things. And the value of ECG is especially in identifying systolic dysfunction. Then let us come to the biochemical parameters. We have the ANPs, the BNPs, and the CNPs. And among them, the most important is the BNP, because what happens whenever there is a myocardial stretch, there is a cardiac cells, they start releasing the pre-pro-BNP, they become the pro-BNP, and they divide into the anti-pro-BNP and BNP. Our now labs, mostly they do all NT-proBNP, and we have to identify if the patient has complaints whether the NT-proBNP or BNP is higher. And based on that, we have to give therapy, that is the neprilysin inhibitors, and these biomarkers are very important. And we have targets for these biomarkers. If this biomarker is raised, we can target the drugs. Now, the European Society of Cardiology and the American College of Cardiology have a class 1 recommendation for doing NT-proBNP, and it is more than 300, possibly a patient has gone into heart failure. But one thing of caution is that NT-proBNP may be raised in various situations. For example, in CKD and strokes, one has to be careful, but please don't go by the report that if it is more than 300, it is always this thing that is heart failure. There is the age variation also. For example, less than 50, it should be more than 450, 50 to 75, more than 900, more than 75, more than 1800, then only you think of heart failure. So please analyze the NT-proBNP reports very carefully. Now, it has been shown that if the NT-proBNP is high, then the chances of mortality and the recurrent heart failure hospitalization is also high. So after ECG, the biochemical parameter is very important. There have been various newer biochemical parameters, the ST2, galactine, microRNA, procalcitonin, MMP, but we don't have an access to all this except in the ST2. The soluble supplement tuberculous ST2 has shown to be associated with adverse outcomes in heart failure and predict mortality risk. In fact, the PRIDE study showed that if the ST2 values are more than 0.2, there were increased risk of death at 1 year. And please remember that inferior to NT-proBNP for diagnosis of heart failure, it only suggests that what is the mortality or the outcome. And this ST2 is now available in many labs, and it can be done. Echo in 1972 is just when Echo started, it was just the M mode, and in 2023, you have to spend almost 40 minutes on Echo because you do the M mode, a 2D, a 3D, a diastole, a strain, a contrast, a Doppler, and there are various factors which can be seen and which can detect. I won't go into all these details because these markers, there are echo markers where you can do phenotyping and prognostic assessment, and also we can know the additional marker for the prognosis. Now, echo has advanced a lot and has in evaluation of heart failure patient, it picks up early heart failure patients. Besides that, the scoring system, the HFpEF system, in which there are various parameters, whether the body mass index, hypertension, atrial fibrillation, pulmonary hypertension, elder, and filling pressure. So you have a score of 9. And if the patient has a score more than 4, the chances of heart failure is very high. So clinically also with echo, you can also know whether the patient has got heart failure or not. These are the various parameters, let them the clinical, the laboratory parameters, the ECG parameters, the chest X-ray, the echo parameters, which all, if compounded, can show very sensitive indices for detecting heart failure early. Now, this was in 2022 when an update came that if the patient is stage A, try to see for the risk factors, go for a pro-BNP. If the pro-BNP is normal, again ask the patient to come after 1 year. Stage B, already when dysfunction has started, either the earliest to occur is diastolic dysfunction, then again you go for a pro-BNP. If it is elevated, go for various imaging, especially echo. And if it is yes, your patient is in heart failure and needs to be treated, because anytime your patient of stage B can go to a stage C or a stage D. Now, why managing heart failure is a challenge in diabetics? Because picking them up is very important, and then also managing them. Now, it is seen that what we as physicians do, we treat both of these as different entities. We have to think about each diabetic possibly having heart failure. And this is one of the most dangerous disease combinations in modern medicine, making the treatment more difficult because you have to be very prudent in choosing the drugs. The next important thing, we have very limited drugs which can prevent heart failure. And many hyperglycemic drugs have been found to have a potential CV risk, which are not conducive to heart failure. So we have to be very selective on drugs, and therefore it's necessary to further explore the treatment plan of diabetes mellitus combined with heart failure. Now, how do we prevent heart failure diabetes? If Kamala Hassan would ask, definitely we have to remember whether it's a rich or the poor, all hearts are equal. And the first basic concept that should go that lifestyle modifications are very important. No smoking, a proper diet, could go away with stress, do exercise, do yoga, do meditation, and this will possibly help more than 50% of a patient. And as Professor Das was telling, no one wants physiotherapy, no one wants also lifestyle modification. They just want drug. And as you see, the 2022 stratification, first was stated that there's a lifestyle modification diabetes, and then we have to have glycemic control, blood pressure management, lipid management, and agents with cardiovascular kidney benefit are very important. Now, great personality, we all at him. Are there drugs that can prevent heart failure? Yes, there are drugs. And when SGLT2 came, it was a big step forward because we started thinking that possibly with this SGLT2 inhibitors can work on this cardiovascular continuum, and it can prevent atherosclerosis. Now, how does it prevent atherosclerosis? This is a narrative review from Nature, which showed that a host of mechanisms and all this help in having prevention of atherosclerosis, and these drugs do modify atherosclerosis. And atherosclerosis is the first stage where the heart failure begins. And if you can start this drug early, these are definitely preventive drugs. Moreover, these are animal models which showed that you can see the intimal thickness when they put on SGLT2 inhibitors versus non-SGLT2 inhibitors. The intimal media thickness decreased when they were put on SGLT2 inhibitors, and this was something very interesting that appeared last year, giving us more confidence that these drugs could prevent atherosclerosis. Intimal media thickness is prevented by DAPA. Now, diabetes-induced myocardial injury markers, the increment was also halted by DAPA. So these were the new evidence that we're getting. And more importantly, recently we've got evidence that DAPA can stabilize diabetes-induced atherosclerotic plaque instability. This is very important. So in the mouse model, which was done, and histopathology studies has shown that if you start DAPA early, you can do a plaque stabilization. So the next question comes, can it prevent myocardial infarction? Yes, it has been shown that it can prevent myocardial infarction. And this was on the rabbit models. You see the control tissues of the heart, what happens in a diabetic, the myocardium. And if you put DAPA, it is almost comparable to the control. So it gives us more evidence. Of course, these are on animal models. These are new studies that are coming up, and also highlights the fact that in the diabetes, if we use SGLT2 inhibitors, definitely it does not become fibrotic. So it is the anti-fibrotic drug which has to be started early. Next, can it prevent heart failure? Of course. The first trial to do was the declared 58, we showed that if you use DAPA, it did prevent this thing, renal composite burns, the deaths, the major adverse cardiac events, and cardiovascular death and hospitalization from heart failure. And it all results in a lower rate of cardiovascular death and hospitalization from heart failure, highlighting the fact that DAPA is started early can prevent heart failure. So the ACC-AHA came with the guidelines that 3 randomized controlled trials have shown that SGLT2 inhibitors can reduce heart failure and can be extended to primary prevention. This was something very important and gave us insight that in 2019, we have taken a big step ahead in having the SGLT2 inhibitors in preventing heart failure. Then came the guidelines from 2018 to 2016. All guidelines started stating and upgrading the use of SGLT2 inhibitors in prevention of heart failure and in treating heart failure. The other trial, which you're all aware, is the DAPA heart failure study, which clearly showed that if the patient has gone into heart failure, if you put these patients on DAPA, they do well. Then came a big leap forward. And this was ARNI, or the sacubitril/valsartan combination. And the 2022 Heart Failure Society of USA and the ACC-AHA clearly stated in patients with heart failure class 2 to 3 symptoms, use of ARNI is a class 1 recommendation for morbidity and mortality reduction. And you have to use ACRB where ARNI is not feasible, or patients with intolerance to ACI because of cough and angioedema, but ARNI is a class 1 indication in patients. So use these 2 drugs, which were previously used as the class 1 drugs. They have been replaced by ARNI as the first drug. And it has been shown that when they use ARNI, there is significant decrement in the NT-proBNP levels, almost 25% reduction in NT-proBNP levels in SAC-VAL combination compared to enalapril, diabetes, and heart failure. So if you detect a patient who is having a high proBNP, you have to put them on the SGLT2 inhibitors and have to put them on the SAC-VAL combination. And let us see which scores best. This was a mortality benefit of ARP, AC inhibitors, and you see ARNI. ARNI has the maximum mortality benefit so far as this thing, that is heart failure, is concerned. So we have to take evidence which is before us and go ahead with the treatment. These 2 gentlemen could never make a ministry. So with the question comes, can we have SGLT2 inhibitors ARNI to prevent heart failure and diabetics? Yes. The AC 2021 guidelines clearly states that SGLT2 inhibitor has to be added with SAC-VAL for patients who are prone to diabetes or have a heart failure. And also this has been endorsed by the ACC 2022 guidelines. And it was seen that when there was a comprehensive therapy of both these drugs, the cardiovascular death, the hospitalization, and the all-cause mortality was significantly reduced. So comprehensive therapy halt or delay clinical progression or heart failure with reduced ejection fraction patients compared to conventional therapy. The thing again went further that these studies like the DAPA heart failure, the Emperor heart failure clearly stated that this combination is much better than giving single drug. So as practicing physicians, we have to move with science and possibly think of this combination. And the pooled meta-analysis clearly indicates that there is a 32% lower occurrence of CV death or heart failure hospitalization, heart failure with reduced ejection fraction when SGLT2 inhibitors are combined with a SAC-VAL combination. A very famous personality because she married one of our famous actors, Priyanka Chopra, Nick Jones. What is the pharmacotherapy to prevent heart failure and diabetes? These were the fantastic 4 for which I have been proposed now as the great things. And these 3 drugs have shown that these are the interventions which has to be given to prevent heart failure and in patients with diabetes. A person who ruled a good economic politician who will ask what are the tips and tricks to prevent heart failure. Definitely, this is what we've done. In stage A, the primary care physician, the dietitian and endocrinologist have to see that, assess it, and they have to start the patient on SGLT2 inhibitors with ARNI, of course. And in stage B, we have to be very careful in medical management. You have try to avoid DPP4, thiazolidines, and sulfonylureas, and try to stick to SGLT2 inhibitors as the most important thing. And most importantly, do a biochemical test and an echo to diagnose your patients. Now, why was I showing all these personalities? They have something in common, and that was diabetes. All these big personalities, whether politicians, film actors, musicians, all have diabetes in common, and they had to fight and are leading a good life in spite of their diabetes. So if you ask me the question, can heart failure and diabetes be prevented? The answer from my side is a big yes. Detect early, Treat early with appropriate drugs, and you'll definitely see heart failure can be prevented. Thank you very much for the patient hearing.